I don't know if anybody hasn't met me yet. I'm Marilyn Telen. My claim to fame is I've been here for 33 years. So I get to talk to you about hemolytic anemias, and in the kind of pace of the way you get all these lectures, I get to talk about immune and non-immune hemolytic anemias, kind of all in the same lecture, which is kind of like reading an encyclopedia. So I have a very encyclopedic set of slides, but I think we're just going to kind of, if you want to ask questions about something, please do, and we'll talk about some of it, and we'll talk. I have some questions that I'm told to do that. So I am going to talk about, in general, signs and symptoms of hemolytic anemia, hereditary versus acquired, non-immune versus immune, and a little bit about therapeutic approaches. So I get to ask you two questions because that's what we're told to do. I used to actually write the questions for the hematology board. I don't think I took ones that I put on the board, but anyway. So I have two cases, and I'm going to present the cases right now, and then we'll talk about them at the end and see blood films and stuff. So this is a woman who's otherwise pretty healthy, comes to the emergency room with fever, night sweats, headache, myalgias, and dark urine. She had a recent vacation in Northern California, and she is status post splenectomy after trauma as a teenager. Her physical exam was remarkable for things that you get when you're sick: tachycardia, tachypnea, a systolic murmur, anemia with a hemoglobin of 9.7, thrombocytopenia, a normal white count and differential, a creatinine that's elevated, and liver function tests that are mildly elevated with an indirect biliary of 5.6, and her DAT is negative, and we will talk about this later. Let's see. And this is another case, an 18-year-old man who complains of severe lethargy following a recent episode of otitis media. He is icteric, he's pale, he does not have splenomegaly. His bilirubin, much like the other ladies, is largely indirect and elevated. His hematocrit is low. His retic count is modestly high. And if you ever work with me, you'll know I never talk about retics in percent. I'm not sure why it is here. But anyway, white counts and platelets are normal. DAT is negative. If you perform a DAT at 4 degrees, it's actually positive for IgG. And we'll talk about that one, just to get you thinking. Oh, I have a third one. I forgot. And this is simply, this is something you might get as a curbside, even though you're not supposed to do curbsides, I don't think. But anyway, this is so you get asked to review a blood film, or you're sitting at the 9100 microscope, and this is a person whose hemoglobin is measured at 14, but whose red cell count is only 2.8, and whose MCV is measured in the CBC is 117. Okay, so when you're thinking about hemolysis, basically you start out because the patient's anemic. Usually you're not thinking about hemolysis if the patient isn't anemic, although I have had patients with hemolytic anemia who were not anemic, but it's rare. So really, whenever you talk about anemia, you have three possibilities, and everything falls into those three possibilities. If someone's hemolyzing, they're bleeding, or they're not making red cells. If you can think of something else, please tell me. I'll add it to my slide, but I think it all falls into that category, and that's something you probably got in medical school. If you decide the patient has hemolysis, you have to then decide whether this is acquired or congenital, and that's probably the first decision tree. If it's acquired, it could be immune or non-immune, and there's a lot of categories that can go under that. If it's congenital, then usually it falls into one of three categories. Not absolutely, but usually it's either an enzymopathy, it's a hemoglobinopathy, or it's a membrane disorder. And I suppose there are one or two things that don't quite fit into those boxes, but that's pretty much my basic decision tree. Again, the laboratory signs of hemolysis are pretty straightforward and standard. The only problem is that none of them are actually necessary to the presentation of hemolysis. They're simply frequent. Reticulocytosis can, like, someone think of a setting in which you will have hemolytic anemia without reticulocytosis? This is a 15 or less second question, so the clock is ticking. Well, you could, for example, have hemolytic anemia that you've had acquired for a while, have a lousy diet, be folate deficient, and not have retic. You could have an antibody-induced hemolytic anemia that preferentially binds retics. It's been reported. It's not very common. Probably the most common setting in which you see hemolytic anemia without reticulocytosis is actually AIDS, and there it's pretty well described. So immune hemolytic anemias, the state of the art hasn't changed much in a long time. Warm autoimmune hemolytic anemia accounts for usually at least 50%, and some report 70% of all hemolytic anemia. It does matter whether you're talking about adults or children in this case, though. And then the warm autos may be idiopathic or may be secondary, and I listed some of the diseases associated with hemolytic anemia, which are probably no surprise to you. Cold-reacting antibodies, the cold-reacting hemolytic anemias are usually IgM-mediated, but not always. There's such a thing called idiopathic cold agglutinin disease, in which the antibody is a monoclonal protein, although you can't always identify it on an SPEP because there isn't necessarily enough of it. If you did an SPEP on immunoglobulin elute in the red cells, you would see it. And actually, we used to do that, but decades ago. Anyway, cold-reacting antibodies occur secondary to infection, but also secondary to lymphoproliferative diseases. Paroxysmal cold hemoglobinuria is basically a cold-reacting or cold autoimmune hemolytic anemia mediated by IgG instead of IgM. It's pretty rare in adults, but it is up to at least probably 50% of autoimmune hemolytic anemia in kids. It's usually idiopathic, although it's believed to probably follow infection, especially in children, but like many things, it's sometimes hard to document that. It was first reported in adults in association with syphilis, but it does occur in association with a bunch of other diseases, including sometimes autoimmune disease. Drug-induced hemolytic anemia is a minority of cases, but probably skewed a little upward in the hospitalized population, and can be very hard to identify as a diagnosis because we do not have standard mechanisms to show the antibody is inducing the hemolysis. So a couple of kind of interesting facts about warm autoimmune hemolytic anemia. Almost always, but not completely always, people will have a positive DAT, and usually they either have IgG alone or IgG and C3. Very rarely will they have C3 only. And what you usually get from the transfusion service is that they've done a DAT, and then either in the serum or the serum in the eluate or the eluate alone, they have found what they call a pan-agglutinin, which simply means because they use some variety of agglutination testing in the blood bank. Nowadays, it's little miniature columns and things, but basically the principle is still agglutination. And so a pan-agglutinin means that no matter what cells you incubate with antibody, they're going to be agglutinated. And the reason for that is very simple. It's that the autoantibodies that people make almost always react to the non-polymorphic determinants on red cells. So that means that everybody has the same thing on their red cells. It may be, for example, a protein that can be polymorphic, but the autoantibody tends to react with an epitope that is not polymorphic. And obviously, your labs can help you identify that the patient does have hemolytic anemia, but if you can't get a positive DAT either in the transfusion service or in the platelet antibody lab, which does the so-called supercoums, which is only mildly more sensitive, actually, then you have to rely on other labs as pointing to hemolytic anemia and other evidence to decide whether you think it's an autoimmune hemolytic anemia. This is just a very faded blood film, and the arrows point to spherocytes, which are normally smaller than the rest of the red cells, so they're sometimes called microspherocytes. There's actually a really good one there. And they look usually a little denser than the rest of the red cells. And also you may see polychromasia, which doesn't show up very well on this film, but you know what it looks like. And that's simply because people have reticulocyte count. So how do you treat? The standard treatment, and there's a really good, I think it's one of those How I Treat articles of warm autoimmune hemolytic anemia that was published in Blood in the last year or two, and that's a really good reference because it's the front line is still steroids of one sort or another. Most patients respond, and most patients respond actually pretty quickly. They necessarily remain in remission once you taper the steroids, and that's where the problems usually lie. But I think, if I remember correctly, the blood paper is helpful because if you read the textbooks, they don't give you a clue how to taper steroids in these kinds of diseases. And for most patients, if you taper them kind of every week or two by half, you will be in trouble before you know it. You really have to go slowly, especially after the first, if you put them on something like a mg per kg equivalent of prednisone, once you're down to about, a dose of 40 or something, you really have to take baby steps in most patients or they're just going to relapse. And the problem with that, obviously, other than they don't feel good when they relapse, is that you then have to start all over again. So it really is not a good idea to put a patient on an autopilot taper for this kind of disease. It isn't for ITP either, but anyway. Splenectomy is often a second-line therapy. It kind of goes in and out of popularity, but most patients respond partially. The other thing that is really important to know, and there's now a lot of literature on this, which there wasn't probably a decade ago, hemolytic anemia, almost of any sort, is a prothrombotic a syndrome, and if you take the spleen out, you have a pretty large risk of thromboembolic disease in the peri-splenectomy period. Patients must go home on something like Lovenox. There's no really good evidence as to how long you should continue some kind of anticoagulation, but they probably need some kind of prophylactic therapy for kind of anybody's guess, but I would say 4 to 6 weeks is probably the minimum. And usually, otherwise, patients get just every kind. They get portal vein thrombosis, they get standard DVTs and PEs. And then immune suppressive therapy, there's a recent paper, I'm not sure where I saw it, maybe in British Journal, on Rituxan, that I thought was kind of optimistic compared to my experience with it, in that I think people respond to Rituxan. My experience is that it's pretty short-lived response, often just months, for a warm auto. Cytoxan is not a very popular drug, and I probably don't use it as much as I used to. Daily Cytoxan works actually really well because it's a good immunosuppressant. Nowadays, we have things that are probably less toxic, like Cellcept, which is probably what I go to more often now. I don't have it on that list. this, I guess, he's updating. The other thing about these patients is they often, because their anemia has been fairly gradual, they often show up very anemic. And you send blood for cross-match, and turn out you thought they had hemolytic anemia to start with. What you find out is that the blood bank says they have a pan-agglutinin, and they say it's going to take X number of hours to get cross-match compatible blood, for the reason that their autoantibody simply binds to all red cells. And what the blood bank's job is, as they see it, is to try to figure out if there are alloantibodies. Because in general, autoantibodies won't cause a hemolytic transfusion reaction or anything that can go along with that, like changes in vital signs and renal failure and stuff like that. But alloantibodies tend to be much higher titer and will cause those reactions. So their job is to sort out what's auto and what's allo, and it's a very time-intensive procedure. Your job is to keep the patient and all their organ systems alive, and so it is your job and not the transfusion service job to decide whether you think the patient needs to get blood without a full cross-match. And that can be one of the most important decisions you make in this context, in the whole treatment of the patient. And so obviously, if they've been transfused before, if they've been pregnant, those are risk factors for them being having an alloantibody in the past. And then giving the transfusion service the history and where they were treated, they call the blood banks there and find out if any antibody was ever found. If the antibody was found, they could at least give you blood that doesn't have that antigen, in addition to ABO and RH matched, which is pretty much never a problem. If it's a man who's never had surgery, the likelihood of him having a preformed alloantibody is nil. So that's where your history gets very important in your decision making. But in general, there's only been something like 2 case reports of people who died from transfusion reactions in the setting of autoimmune hemolytic anemia where an alloantibody was missed. I mean, not that they can't have the reactions, but usually the anemia and the primary process is more life-threatening. So, this comes into play, obviously, when you have someone who's a hemoglobin of 5 or something like that, especially if they're not a sickle cell patient and they're used to living at 13. So, usually transfused blood will survive no better or worse than autologous blood, unless, of course, there's an alloantibody. So I just, use your clinical judgment, but don't be afraid to sign a conditional release when you think the patient is in danger of infarcting an organ or infarcting their brain or their heart in this setting. Because with older patients, they certainly run that risk. Cold agglutinin disease, the DAT will usually show just complement but no IgG. The polyspecific may be positive, usually positive. And antibody specificity is most often big I or little I. And so you should recognize that as a clinically significant thing. The blood bank compares reactions with adult and cord blood cells to make that differentiation. But it does have clinical import from your point of view. And usually, if the blood is drawn correctly, which is in warm, transported warm, and it goes to the platelet antibody lab, which does the cold agglutinin titers, not the blood bank, usually you'll see a titer of over 1 to 100. Typically, a person with cold agglutinin disease has titers in the thousands. But you will see a blood film like this sometimes with agglutination on the slide, and this is very different from rouleau because these are really clumps and not kind of chains. So your kind of benign, so-called benign idiopathic cold agglutinin disease should have an anti-big I. You might see the small monoclonal spike. Typically, these patients often have acrocyanosis or Raynaud's. If you have cold agglutinin disease from an infection, usually it takes a couple of weeks to develop. And the two we see most often are the mono-associated cold agglutinin hemolytic anemia, which typically has an anti-little I. So mono patients can also get warm autos. And mycoplasma typically gives you an anti-big I. If you have a patient who has an anti-little I with a setting of mono or another infection, and especially if they're older, you really do have to think about lymphoproliferative diseases, because that is kind of lymphoma till proven otherwise, if it's an anti-little I without a history of something like mono. There's actually an old case report in the New England Journal about this, because the case report basically got, there was an older woman, she had a cold agglutinin disease with an anti-little I. She was treated with steroids. We'll get to that in a minute. She didn't respond, which is not surprising, and then they finally looked for the lymphoma, at which point she was so tired of being sick she refused treatment and died. Not a good thing. The first treatment for cold agglutinin disease of the idiopathic or cold agglutinin, the monoclonal cold agglutinin disease, is really avoidance of cold and supplementing folates. Steroids are basically never helpful in that. So plasmapheresis can be helpful, but it's temporary. This is a case where Rituxan has been well demonstrated to work. Other immunosuppressive agents are not well studied, I would say. And if a patient really has brisk intravascular hemolysis, which is due to, so even colds, even though they activate complement, often have extravascular hemolysis. The complement doesn't, it's not deposited enough, and it really acts as an opsonizing agent in the reticular endothelial system and not really causing intravascular hemolysis. But if you think you have good evidence for intravascular hemolysis, you can use eculizumab, although it will cost somebody an arm and a leg to do it. But it's been described, although only in a few cases. It's secondary to infection, like mono, it actually may respond to steroids. And if it's secondary to lymphoproliferative disease, you have to treat the disease. And as you probably know, when you treat CLL, sometimes the hemolytic anemia gets worse, or it gets worse before it gets better. Cold agglutinin disease, transfusion in this setting is a really kind of interesting phenomenon, because what happens in cold agglutinin disease is you get IgM, you get complement deposit on the red cell, complement activation, and complement inactivation. And the inactivated complement on the red cell actually protects the red cells that are the patient's own red cells. So when you give transfused blood, even through a blood warmer, you get a certain amount of what I call a first pass effect. Is there's kind of a clearance of some of the red cells very quickly, and then the rest kind of survive like the patient's red cells. And that's because none of these red cells are protected by their complement degradation products. So paroxysmal cold hemoglobinuria is the last immune, well, except for drugs, the last immune-mediated thing I'm going to talk about. And basically, you can think of it as reacting IgG. Erythrophagocytosis is a not infrequent blood film sign. And that's what it looks like. So if you ever see this, this is probably the first thing to think about. Sometimes the DAT is negative, which makes it very frustrating. Sometimes it's just positive for C3. You can do a Doneth-Landsteiner test, and the platelet body lab does a cold DAT, I think. Or they have a version of a Doneth-Landsteiner test where they don't look for hemolysis, they look for antibody binding. And antibody specificity is usually P, which is when you look at things, when you see reports about antibodies from the blood bank, sometimes they say someone has an anti-P1. P is kind of the substrate that you make P1 on, and so while not everybody's P1 positive, everybody short of 1 in about 1,000 or less is P positive. Sometimes this responds to steroids. If it doesn't, it usually responds to other immunosuppressive agents. So drug-induced hemolytic anemia is a problem diagnostically because there are a few drugs like penicillins where it absorbs onto the red cell, and we can actually take the patient's plasma and some penicillin and incubate some red cells in penicillin and then show that the patient's plasma reacts with the red cells that were coated with penicillin but not with the uncoated ones. But for the rest of these, for the rest of the drugs, we don't have any really good way of doing it. And so we have, I would say, kind of beta versions of most of these kind of tests. We'll try, but it's hard to do. And then there are some drugs that simply cause autoimmune disease, if you will, some of which we use still fairly frequently. I guess procainamide doesn't get used much anymore. Aldamet doesn't get used anymore. So for drug-induced, you really have to think of the diagnosis. You can use the blood bank to try to demonstrate the antibody, but if that's not possible, you still have to be thinking about the diagnosis. And then, of course, there's alloimmune hemolysis. That's really a transfusion lecture. But you can either get that from antibodies that the patient or the recipient produces, or in solid organ transplants, you can get antibodies produced by the organ or by the lymphocytes that came along with the organ, in which case it's called passage of lymphocyte syndrome. Usually the latter is self-limited. The former, they're both self-limited because in the case the lymphocytes die off and they have a lot of immunosuppression, so they don't hang around. In the former case, once you hemolyze the blood that is incompatible, you stop hemolyzing unless you're a sickle cell patient, which I won't talk about really anymore. So non-immune hemolytic disorders. Basically, as I said, there's membrane disorders, enzymopathies, and hemoglobinopathies. It's important to kind of understand that the red cell has a cytoskeleton and has lots of different proteins that are part of that cytoskeleton, and anything wrong with most of them will cause hemolytic anemia. There are some also integral membrane proteins that will cause hemolytic anemia if you don't have them or if you have abnormal forms of them. I've listed the ones here: glycophorin C, Rh-null, and the protein called AX, which when you're missing it causes neuroacanthocytosis, are the ones that are associated with blood group antigen expression. So enzymopathies usually cause non-spherocytic hemolytic anemia, and there's a whole list of those. The thing is that most of these things are not things where you diagnose them for the first time in adulthood, although the glycophorin C and Rh-null abnormalities are ones that can go undiagnosed till adulthood because they cause only a very mild hemolytic anemia. And so, like, I saw one patient who really wasn't figured out that he had Rh-null syndrome until he had lung cancer and needed a bunch of transfusions for hemoptysis. So this is a schema of all the different proteins, and I'm not going to go over that. Usually when they're diagnosed in a lab, which my research lab can do, but which in general isn't done here, but which you can get in a place like Mayo, they look at all the quantities of all these things. Most, but not all, of the abnormalities of these proteins will cause abnormal quantities in the membrane. And then you have the transmembrane proteins, and they link in a variety of ways to this cytoskeleton, which looks, if you saw an EM of the cytoskeleton, it would look like a Buckminster Fuller geodesic dome, if any of you know what that looks like. So there's attachments that these filaments have to each other, and then there's the attachments they have to the membrane. And so they're sometimes called vertical and horizontal defects, but in general, they cause abnormal resistance to hypertonic lysis, and so you can get osmotic fragility done, which again we no longer do here, but which Mayo does. The most common ones you see are hereditary spherocytosis and hereditary elliptocytosis. Spherocytosis can be dominant, recessive, or is not infrequently actually have a patient who's actually inherited two different spherocytosis genes. It's actually not uncommon. They have very variable degrees of hemolytic anemia, and they're not always consistent in families. But usually you see spherocytes, they have progressive splenomegaly over the course of their life. They have reticulocytosis, usually only mildly elevated bilirubin by itself, except for very severe forms. You won't see a bilirubin in when the patient's healthy that's above about 2.5. And they have increased osmotic fragility. They do get gallstones, sometimes fairly early. They can get aplastic crises, both from parvovirus, and I've seen them from various influenza viruses. They can get megaloblastic crises if they have lousy diets, which a number of teenagers do. They can sometimes get leg ulcers. They also get DVTs, and hypersplenism can occur anywhere. In most of these, it rarely occurs until a patient's at least 20, but it can present in someone in their 60s or in between. Of the different types, about half of them have spectrin deficiency, usually due to genetic abnormalities either in the spectrin genes or the anchorin genes, which then cause an anchorin that doesn't anchor spectrin the way it should. About 30% have partial band 3 deficiency due to band 3 defects, and then there's an assortment of other things. So here is a picture of a patient with hereditary spherocytosis. There's big cells, and then there's kind of small spherocytic cells. And this is the kind of thing you see when you do an osmotic fragility test with normal but only lysing at relatively lower concentrations of salt, whereas in hereditary spherocytosis you don't need to get that much below physiologic saline to start seeing lysis. And usually you get a curve that looks like this, where they show you where the normal curve is and where their control went and where your patient is. Elliptocytosis is common but less severe and often goes undiagnosed. It's usually dominant, and it's fairly frequent in African Americans, but then most of them are asymptomatic. And usually, to make the diagnosis, you see more than 15% elliptocytes. Some textbooks probably say 20%. And this is what a film would look like. You do see these kind of elliptocytes sometimes in iron deficiency, but there you see someone who's also hypochromic, which this film clearly isn't. There's a bunch of other abnormalities. Hereditary pyropoikilocytosis is also seen in African Americans, gives you severe hemolytic anemia, microcytosis, and there's a couple of families in eastern North Carolina with this. And they have just a mess of cells, so they have big cells, little cells, kind of cells that look half empty, cells that look dense. You can have pyropoikilocytosis in neonates that then get better as the baby gets older. Southeast Asian avalocytosis is something we see more because we have more immigrants from that area of the world. And this is one of those abnormalities that's associated with resistance to malaria. and basically winds up giving you a band 3 deficiency. But it's common in that part of the world. Stomatocytosis can come from actually a number of different genetic abnormalities, including the Rh-Bell syndrome, but also including something called stomatin and actually some other proteins too. This is one of all these syndromes where you should probably never do splenectomy. But it's very hard to diagnose, but you have to really think about that if you really have a patient with stomatocytes. And this is what stomatocytes look like. They have that linear white space in the middle, and that's because, if you look at me for a second, it's because the cell is kind of folded like that. So it's uniconcave instead of biconcave. Acanthosis is an example of acanthocytosis, and there are hereditary defects that cause it. At least one of them, the KX, that causes neuroacanthocytosis, is on the X chromosome. So you will see in women, you will see 2 populations of cells. Enzymopathies, there's a very long list. We can test for glucose 6-phosphate deficiency and pyruvate kinase deficiency at Duke. Everything else gets sent out. I'm not going to go through this because we don't have time, but G6PD deficiency, especially in African Americans, is relatively asymptomatic, but may get worse when the patient's sick, when the patient has an infection or is pregnant. And this is an example of some of the abnormalities you see with these kind of bite cells, and sometimes these blisters and the Heinz bodies, which is you see in the lower film. Usually pyruvate kinase deficiency. So G6PD is X-linked. You probably all know that, right? Pyruvate kinase deficiency is usually recessive, and is usually mild, but again will cause cholelithiasis, will cause splenomegaly that sometimes requires splenectomy, and will cause sometimes severe anemia during pregnancy. Methemoglobinemia sometimes will cause hemolysis. Usually is more noted for causing cyanosis. So one thing that we don't always think about until it hits us over the head is physical damage to red cells. When we do think about it, we usually think about it in the setting of DIC, in the setting of usually prosthetic or non-biologic heart valves that have been used to replace valves, and that can certainly happen. Other settings that you can see it in are in patients who've had extreme heat exposure or severe burns, and also patients with aortic aneurysms. Okay, I think I'm going to end on time. So back to questions. The first question, the 37-year-old female, history of splenectomy in probably about 20 years ago, history of domestic travel, now has hemolytic anemia, thrombocytopenia, and renal dysfunction. I hope the next one is, and that's her slide. What else? Come on. Yeah, who said that? Yes, actually, there's an interesting. Anyone who gets the New York Times, there's an interesting article about babesiosis in the New York Times magazine section yesterday. It's actually a really good article about babesiosis in the New Yorker, but it's years ago. I don't know why it's so popular in the lay press, but anyway. So this patient actually, though, wound up having transfusion-acquired babesiosis, they thought, and had a severe course because she was splenectomized. The incubation, so the BCA are seen on both coasts, mainly in the north, so the northern Pacific coast, the northern Atlantic coast in this country. Can also be seen as far south as Long Island, though. Can be several weeks to even a couple of months incubation period. Usually, could often be a mild disease, but can, if it is symptomatic, it's kind of a flu-like illness usually with fever, malaise, and myalgias. Can cause renal and hepatic dysfunction as well as hemolytic anemia. And so, how do you treat babesiosis? Someone shout out. Well, I think actually the last two are both satisfactory, the clindamycin and quinine, or the azithromycin and atovaquone. Nowadays, I think most people use azithromycin and atovaquone, but it's treatable. The Times article was an interesting patient who had was sick with kind of typical symptoms. It took quite a while to get better, but she was starting, a middle-aged woman, she was starting to get better, and then she had acute decompensation. And her acute decompensation turned out to be due to splenic rupture, which occurs as a rare complication of babesiosis, and whose, according to the New York Times article, and I did not have time to look this up last time, the pathophysiology of why you get that is unknown, but anyway, but it is a rare complication. This patient had splenectomy already, so we didn't have to worry about it. Okay, question 2. So this is a young man, younger person, who had otis media, and then had cold reacting IgG. If you remember, they chilled everything up and did a Coombs test, and then they got IgG on the cells where they didn't get anything when they did a regular DAT test. And so the antibody to confirm that would have been a routine Donner-Landsteiner antibody, and the target antigen is? The target antigen is P. There's actually some of the, like what they call the Amish, I guess it is. There are a couple populations in the United States and Canada that actually are P negative. P is also the target receptor for parvovirus. It just happens. So that's kind of a maybe a question. It's one of these things that it's sort of hematologic trivia, but we do actually have one patient who is PA negative, so she has none of this whole P structure on her cells. And although the advantage is that they're resistant to B19, not B12 parvovirus, the disadvantage is that if you're TJ negative and you're a woman, you have a much higher frequency of spontaneous abortion than the rest of the population. Question 3. So you have a CBC with a red count of 2.8 and a hemoglobin of 14 and an MCV of 117. What does this patient have? I can't hear anything.
First one?
I'm sorry? No, I think the reason you said that is because with a high MCV, you're thinking, well, maybe these are ticks. Mm-hmm. But the field discrepancy, you have to remember what the CBC machine actually measures, right? So it only measures 3 things, and then it calculates everything else. So what does it measure? So it measures hemoglobin directly. What does it measure? So the hemoglobin is 14, and that's probably accurate. The hematocrit is 33, which sounds a little low for hemoglobin 14, but it's calculated, not directly measured. So it's the hematocrit that's probably wrong. What else does this machine measure directly? So it works a little like a flow cytometry machine, right? So, or basically without a fluorescent antibody attached to anything. So, but it measures events. So it measures red cells. It actually counts. So it measures things crossing its sensor, right? So it counted red cells as 2.8 when the hemoglobin was 14, and it also measures MCV, which probably, otherwise you would have calculated the MCV to actually be higher than 17. But anyway, so what happened here is that it's measuring red cells that are stuck to each other. So the hemoglobin is normal. The MCV is high because the red cells are stuck to each other, and MCV is a mean. So, I did the RDW, which is probably enormous, but that means so that's why it's not hereditary spherocytosis. Right. So it's probably an IgM sticking the red cells together and causing this. So it is, as a hematologist, you do get asked, curbs or otherwise, to make sense of lab values that occasionally people are astute enough to realize don't make sense. And so you got to figure out how to do that. So here's the answer. Usually this pattern is typical of cold agglutinin disease or diseases with cold agglutinin. And we've talked about the rest. So back to the decision tree. It's 11:32 by my watch, but if you have questions, I'm going to answer them. Or 12:32, rather.